somebody has compared the various psychological parameters between brain surgeons, rocket scientists, and general public. Next slide, please. And what was interesting in this paper was that among all domains, if you compare rocket scientists versus brain surgeons are good in semantic problem solving, whereas rocket scientists were good in mental manipulation and alterations. So that was one thing that was found, but the rest, everything, there was no difference between the rocket scientists and the brain surgeons. Next slide, please. And if you compare the rocket scientists and neurosurgeons versus general public, it was very surprising to note that there was no difference between general public and rocket scientists. Whereas neurosurgeons, of course, did badly in the memory recall, so apparently we don't have that much of memory. Whereas in terms of problem solving, neurosurgeons were far better than general public or rocket scientists. The study was published recently. Next slide, please. So there's the difference between perception and reality. How do you know if there's a neurosurgeon in the room? Easy, they will have already told you that they are there. And also there's a sort of general public perception that they have a massive God complex and they're hugely egotistical, and neurosurgeons incredibly delicate and nuanced. Next slide, please. But the reality is that neurosurgeons are some of the hardest working people in the hospital. They work most challenging and demanding hours, and their lifestyle is nothing to be envious of. Next slide, please. So in popular culture, the term brain surgeon is used to describe a very smart person, and for good reason. In order to excel at neurosurgery, a person must be in the top form both intellectually, physically, and emotionally, because the training is so draining. We do perform the most delicate and time-intensive work on brain and spinal cord, a job that requires many years of training and strong emotional resilience. Next slide, please. So I'm Girish Vajramani, one of the neurosurgeons. I set up the Center for Functional Neurosurgery at the Wessex Neurological Center. I'm a Mr., by the way. So there's a difference between Misters and doctors in this country. So when it all started, the physicians thought they're quite clever people, whereas they wouldn't allow surgeons to become doctors. So when the surgeons started their training, when they started cutting human bodies, they had to be affiliated to Barber Society. So we are all part of Barber Society. So that's why they wouldn't give the title of doctor to a person who's doing a cutting of human body. And that tradition has continued since then. So you become a doctor, and once you train as a surgeon, you get the title of Mr. And that's to be proud of. Once you get a Mr. title, that means you're a surgeon. Next slide, please. So I do follow a long tradition of neurosurgery going back to 7,000 years. During sort of ancient time, there were neurosurgeons who were doing procedures like that, called trepanations. They had, they knew that brain is somehow involved in various neurological and psychiatric diseases. And although they didn't know what to do with it, or they didn't know anything about it, in fact, nothing much has changed of late. We still don't know much about it. But they would do drill holes in the skull they thought that it's all because of evil spirit, and by drilling hole in the skull, the evil spirit would come out. And that was there, this one. So in certain areas, in fact, about 2 to 5% of all human skulls had signs of trepanation, making holes in the skull. And there were sort of specialized instruments for that as well. Next slide, please. So neurosurgery has come a long way since then, of course. And we owe much of the modern neurosurgery to this chap, Sir Victor Horsley from Queen Square in London. He was one of the pioneers of neurosurgery, almost a father of modern neurosurgery. He devised sort of various operations and made neurosurgery quite safe in London at the National Hospital for Neurology and Neurosurgery. And Queen Square is still considered Mecca of neurosurgery. The other two giants are, next slide please, Harvey Cushing and Walter Dandy, both from America. Harvey Cushing, in fact, is considered as the father of neurosurgery. Walter Dandy was his student, but both are quite towering giants in neurosurgery, and we owe much of our neurosurgical knowledge to these three people. So neurosurgery is what I do, and once you train as a neurosurgeon, you then have to subspecialize in various branches, and these are all the various subspecialties that I have listed here. So some people go to do pediatric neurosurgery, neuro-oncology neurosurgery. Some people do specialize in skull-based problems such as skull-based complex tumors and other pathology. There'll be a spinal neurosurgeon. Functional neurosurgery is what I do, and I'll tell you what it's all about. People deal with neurovascular neurosurgery, aneurysms, and arteriovenous malformations. Or somebody may just do general neurosurgery and trauma. So these are all various subspecialties that you have to do. In fact, Southampton is a highly subspecialized department where each of us do only some certain aspect of neurosurgery. Very few people do sort of general and trauma. So the reason I sort of went into neurosurgery was when I was a medical student, I came across this book called First Do No Harm. In fact, it was sort of published as a book section in the Reader's Digest, and that sort of had a very nice description of the making of a neurosurgeon. How rigorous was the training? How is the life of a neurosurgeon? The triumphs and the tribulations. So it was a fantastic sort of description of a neurosurgeon, and that's what inspired me to join neurosurgery. Brain is such a fantastic organ. Next slide, please. So this is Creation of Adam, which is one of the frescoes in the Sistine Chapel. Any sort of, can you see anything familiar there? So this is God creating Adam, and this is a famous sort of painting in one of the roofs there. Michelangelo, in fact, was a neural anatomy person. He did quite a lot of dissection, but when he was working he was a patron of Pope. He was not allowed to do any dissections or do anything to do with human organs. So he couldn't depict any sort of. He was a painter, and he wanted to depict, neuroanatomy in his paintings, but he was not allowed to do so. But what he did was cleverly hide the anatomy of brain in his paintings. So if you see this next slide, this is actually sagittal section of a brain, where you're seeing God is sort of handing over all this one to Adam via his prefrontal lobe, so that part of the brain which is involved in intellect. That's the pituitary stroke, and that's this brainstem and spinal cord. So this is a structure of brain that is hidden in that painting. Okay. Next slide, please. So this is the separation of light from darkness, another fresco in the Sistine Chapel. That's the God there. Again, quite a lot of neuroanatomy is hidden in that painting. Nobody would notice it, but if you go clearly, see carefully, you will notice structures there. Next slide, please. So this is what it is. So he has painted several necks, several person necks there. So every time he paints normal neck, but in this particular, he has actually, what he has done is he has painted the ventral surface of brainstem. So you can see that the medulla oblongata, the pons, on the structures of brainstem, as well as you can see that that's the spinal cord going down with anterior median fissure of the spinal cord there. So he has sort of hidden the structure of brain there in his paintings. Next slide, please. Brain, of course, comes color-coded, not in real life, of course. But yeah, you have to sort of know which part of the brain supports what sort of function. So the neurosurgery is one specialty where your anatomy knowledge has to be very sound. Otherwise, you won't know what you're dealing with. Next slide, please. So I started part of my training in India in this place called Nimhans in Bangalore. This is a crazy place, actually, I have to say. There's no concept of, when I came to this country, there was this new thing came called European Working Time Directive, where you're not allowed to work beyond sort of 6 hours, 8 hours. Whereas when I was in training there was no concept of that. So twice, 2 days in a week, you're not seeing sunlight at all. So you come in the morning, 8 o'clock, you finish your day at around 9 o'clock, you go to pub and go and discuss all the patients in pub, come back, operate next day, and when you're on call, you can't see sunlight at all. Your juniors will get the food for you because you're operating continuously for 48 hours, 72 hours. That sort of training it was. Just quite a hands-on training, but that sort of, it gives you all the grounding to become a neurosurgeon. Next slide, please. And when I came here, of course, I did part of my training in Southampton General Hospital, and I went on to do a fellowship in Wharton Center for Neurology and Neurosurgery in Liverpool. That's where I did my subspecialty in functional neurosurgery. Next slide, please. And then when I came back in 2010 as a consultant, I set up the functional neurosurgery because prior to that, nobody was doing functional neurosurgery. And I had to set up this, quite a bit of hard work there. So what is functional neurosurgery? I get asked this question from many doctors actually. Even hospital doctors are not aware what is functional neurosurgery. They always ask, what is functional neurosurgery? Does that mean that other neurosurgeons are not functioning? Is that you only work? No, it's not like that. Functional neurosurgery deals with function of the brain. So you're trying to improve the quality of life. Unlike, say, if there's a brain tumor on the scan, you can see a tumor and you operate on that. Whereas in functional neurosurgery, your scans are normal. Okay, there's nothing to remove or do. But yet you're trying to alter the neuronal circuitry to improve the quality of life. That's what is functional neurosurgery all about. Next paragraph. So it deals with sort of 5 main category of disorders. Chronic pain. So chronic pain, you can't, there's nothing on the scan to see. By and large, it's a normal scan, but the patients are suffering with chronic pain. So that's one huge area that I treat. Movement disorders, Parkinson's disease, dystonia or essential tremor, where you need to put some electrodes in the brain or do some lesioning procedures to control the movements. Epilepsy surgery. There are a lot of patients who have chronic epilepsy, and some of them are amenable to surgical intervention, so that's what I do. Spasticity. A lot of neurological disorders end up with patients having severe spasticity in both arms and legs. How do you then treat those patients if medical management has failed? Then I deal with trigeminal neuralgia and other neurovascular complex syndromes. Okay, I'll come to each of these very briefly. Next slide, please. So these are some of the sort of complex operations that I do. And not everybody does these operations. They are quite rare operations, which I do. Next paragraph. You, of course, need a multidisciplinary team without which you can't do functional neurosurgery, because it's not, the surgery is only one aspect of the whole treatment. So you need psychologists, you need neurologists, you need the neuromodulation nurses, you need the research nurses. So you need a big team to be able to do functional neurosurgery, and that's my team, which is of various sort of people in that. Next slide, please. So I'll come to spinal cord stimulation and tell what it's all about. Basically, patients who have chronic pain, where they have tried all medical management, they're still suffering from severe chronic pain. Pain is such a double-edged sword. You need pain. That's why God has created pain. Because if something is wrong, you need to be alerted that there's something wrong there. So pain is a good thing. But when it becomes chronic and intractable, patients do suffer. The quality of life is poor. Their mental health is affected. And quite often, the patient becomes suicidal. So they go to pain clinic, try various medication, try the psychological treatment, mindfulness, CBT, etc. Nothing works. They're still in severe chronic pain. What do we do then do that? So that's where they refer to me to put electrodes in their spine to block the pain signals. Next slide, please. So this is based on a gate theory which was proposed by Mazrak and Wall in London. So basically you have fine touch and vibration on one side and pain and temperature on one side. And depending on whichever is the dominant traffic, through the gate, those signals go and then reach the brain. So by placing an electrode artificially in the spinal cord, over the spinal cord rather, you're trying to improve the pathway such that the pain signals are getting blocked. So although your body is still generating pain, it's getting blocked at the level of spinal cord. It doesn't reach brain. And that's the sort of basic way how spinal cord stimulator works. We'll go to that next paragraph. So this is what it involves: implanting electrodes there. You may have to put some extension wires, and then you have a pacemaker-like battery there. So those are the components of spinal cord stimulator. Of course, over the last, this has been there for the last 40 years, but last 10 years the technology has advanced so much that we have fantastic devices which are able to control various types of pain syndromes. Next slide, please. So those are the types of electrodes that we implant. Those are percutaneous or spaghetti wire-like electrodes, and these are paddle-shaped electrodes which are surgically implanted, whereas those spaghetti electrodes can be implanted through a percutaneous needle. So I just have to insert a needle into the spine and X-ray guidance, and through that I thread the wires in. Next. Those are different types of pacemakers. There are rechargeable batteries and non-rechargeable batteries. They have to charge every day or once in 1 to 2 weeks, depending on the company, and it's all Bluetooth-based charging. Next one. And these are different companies that manufacture the device. Next one. So this is how we implant do a trial first to see if it works or not by putting a needle, and then through the needle we'll thread the wires into the spine, and then do a trial. Next one, please. So that is connected to an external battery. So this is patient is undergoing a trial with the battery outside. So they go home, use this device for 1 or 2 weeks, and see if it blocks the pain signals. And if it gives more than 50% pain relief, we say the trial is positive. They then come back for stage 2 implant. Next one. And this is if they want a paddle electrode as a definite implant, we'll have to open the spine, put the electrodes, and then put the battery. Next one. So that's, as I was telling you, the recent advances have been quite significant and enormous, especially last 10 years. We have now different types of stimulators with different waveforms, which we can use it to treat our patients. One particular one which has completely changed my practice is this high-frequency stimulation. The difference is the normal spinal cord stimulator works at 40 to 60 hertz, whereas the high-frequency works at 10,000 hertz. So it's quite a big difference. So for the last 40, 50 years, we could treat a leg pain or arm pain, but not back pain. So treating back pain was almost like a holy grail. Nobody was able to control that back pain. Whereas with the advent of high-frequency stimulation, we are now able to treat both back pain and leg pain, or neck pain and arm pain, and that has completely changed our practice. Next one, please. So that's the type of pain scores you see in patients who have stimulators. They start off with pain around 8 out of 10, which is pretty severe pain, and post-implant it comes down to 2, 1, or even less than that sometimes. Okay. Next one. This is a dorsal root ganglion stimulator. So if the pain is very focal, so I know that which dermatome it is or which nerve root is supplying that, I can go and target that particular dorsal root ganglion. Dorsal root ganglion is sort of a collection of nerve cells there, where you have the cell body, neuronal cell body there. So I can target that by placing an electrode there. It's much more advantageous than putting a spinal cord stimulator. Next one. So I know where the dorsal root ganglions are situated on X-ray. Next one, please. I can then go and insert the electrode which comes out of the intervertebral foramen, and it stimulates the dorsal root ganglion there. And the patients get fantastic pain relief with this as well. Next one. That's how it looks on the side view of the X-ray, where it has come out through the intervertebral foramen. Next one, please. And that's how the battery looks like. I mean, we can practically, if I know which sort of dermatome is involved, I can target that particular nerve root. Next one, please. Next one. So this is a bilateral L5 for foot problems. This patient had complex regional pain syndrome. Next one, please. This one had a severe left foot pain due to crush injury, so with L5 on one side. Next one, please. This one is, there are many patients that I get who, following knee replacement, end up with severe chronic neuropathic pain due to nerve damages around the knee. And so I implant either 2-level or 3-level DRG stimulators at L2, L3, or L4. New one. Sometimes we combine the DRG with the standard spinal cord stimulators as depicted here. Next one. So this one patient had undergone a thoracotomy, which is opening the chest, and he was left with severe pain along the scar. So then I targeted the left T8, thoracic 8 nerve by putting the electrodes there, and he had fantastic pain relief. This one is on the cervical spine, who had CRPS, is complex regional pain syndrome, affecting the upper limbs. So I had to target the C4 nerve root there. I think we'll just skip through this. So the other advance has been burst stimulation. Normally, your natural neuronal firing is in a burst mode. It's not a continuous neuronal firing, neuronal activity. So by replicating the normal neuronal firing, you can get a better pain control, which is what this burst stimulation is about. Next one, please. So that's how you stimulate in a burst mode rather than a tonic mode, which again works really well because, next one, it not only acts on the gate theory, but it also affects what is called as the psychological aspect of pain. So although the patient still has pain, they're no longer bothered by it. Okay. Next one. This is an interesting technology which Medtronic has. It's similar to your iPhone or Samsung technology, where if you change the screen, the whole thing changes as well. Because the spinal cord is on the electrode is on the spinal cord, and if you change the position or posture, the spinal cord may be closer to the electrode or away from the electrode. So if it's very close to the electrode, suddenly they'll get extra stimulation. So what this does is exactly like your iPhone technology, it alters its stimulation. So if the spinal cord is too close, when they're sort of lying on their back, it reduces the strength of the stimulation. Next one, please. There are the new fancy things called closed loop CS, where it sort of detects signals from the human body and then adjusts the stimulation. Next one. We then implant occipital nerve stimulators for intractable migraine and cluster headache. These are very complex problems which is difficult to treat. So where I've tried everything, then I implant these electrodes across the occipital nerve and then implant a pacemaker like battery, and that works really well. Next one. This is a spinopalatal ganglion stimulator, which again is for cluster headache, which avoids all the attacks of the headaches. Next one. These are sort of very complex pain procedures that I do called res lesioning in patients who have severe motorcycle accident and they're left with severe pain in the upper limbs. I cut part of the spinal cord to control the pain. Next one. Cordotomy is for cancer pain. Normally we do cordotomy in the neck, and it can only be done on one side. So if you have a cancer, say, affecting the arm or chest, and then in severe pain, you can cut the tract to make a lesion in the tract, which is used for pain signals. Okay, so by interrupting that pathway, you can control the pain. But you can do in the neck only on one side. You can't do it on both sides. Next one, please. So this is where we're cutting the sort of spinal thalamic tract to interrupt pain. Next one, please. But if the patient has bilateral pain, you can't do it in the neck because you end up in what is called as Undine's curse. So this is one of the sort of very enchanting mythical tales in medicine. Undine was a nymph, and she had given a curse to her husband who was cheating on her, and the curse was that he can breathe only if he's awake. The moment he sleeps, he's not able to breathe. Okay, so that was the curse that she had given. So exactly the same thing happens if you do bilateral cordotomy, or if there's injury to high cervical spinal cord. They get Undine's curse, where if they fall asleep, they're not able to breathe properly, and they can only breathe when they're awake. Okay, so that's when I do a bilateral thoracotomy in the thoracic spine. Next one, please. Where this is the intra photograph where I've exposed the spinal cord and sort of made a cut in the spinal cord here, and these are the tracts which sort of serve pain. So by cutting that, the patient becomes pain-free. Next one. And then this is the exciting thing about movement disorders, where we treat these three diseases. There are sort of various neuronal circuits which are involved in these movement disorders. There are rogue cells which are either functioning less or very hyperactive. So we need to treat those rogue cells by either lesioning technique, next one, where we destroy a part of the brain, or by putting deep brain stimulators, where you stimulate the brain to control that. Next one, please. The key thing is these are all very tiny structures. It's very difficult to target that. Next one, please. So I'll just talk about thalamotomy. Next one, please. So these are the sort of type of lesion that you make. So tiny lesion that you have to make in certain crucial part of the brain. Next one, please. And we make use of these stereotactic frames which are attached to the head, and that will help you guide the electrode in that particular area of the nucleus. Next one, please. And there are different types of the stereotactic frame. Or sometimes we use, next one, robotic system, Next one. Next one, please. Keep going. Keep going. Next one. Yeah. So these are the robots that you can use it to help you guide your electrode there. Next one, please. Or sometimes you can use frameless systems, which I don't use it. Next one. So this is an example of a boy. This boy was quite brave, actually. He had a brain tumor which was removed, but then he ended up having extremely severe tremor. Next one. So you can see how shaky he is on just on one side. Okay, next one. And he was getting quite depressed because of that sort of tremor. And next one. And it's all involuntary. He's not able to control those movements. Okay? And next one. And this is after the operation. So I did a thalamotomy. He was awake. I was not sure whether he'll cooperate with me or not. He was a young boy, but he was quite brave. So we did the surgery when he was awake. And this is following the thalamotomy. See, all the shakiness has gone. Next one. You can see how steady he is there. And the next one. Okay, so that's what you do in thalamotomy by sort of putting a probe and burn part of the nucleus which is sort of overactive. Okay. The other way of doing it is there's a latest technology which hasn't come yet on the NHS, but you can also guide ultrasound waves without opening the head to destroy a part of the brain. It's called focused ultrasound treatment. Soon it's going to come. Next one, please. But what we have is a deep brain stimulator. So in all young patients, we do deep brain stimulators. That particular patient, although was young, because his tremor was only on one side and he had a brain tumor, I didn't want to put any implants in. But majority of the patients who have Parkinson's disease, tremor or dystonia, we implant these sort of electrodes in the head and connect it to pacemaker like battery. Okay. Next one, please. Next one. In fact, Southampton was one of the pioneering place where DBS started in the history of DBS surgery. Jason Bryce, who founded the Wessex Neurological Center, in 1980s he used to do deep brain stimulator, whereas the modern DBS era starts in 1990s. Next one, please. So this, again, patients are awake. This is intraoperative.
Yeah, it's complicated.
Tremor is. So patients have to be awake for you to test whether you're in the right place or not. You can see the stereotactic frame attached there. Next one. So you start stimulating on one side. You can see that the left side has become steady now. You just leave the stimulation on one side. And that's where you do all the microelectrode recording. So you're really recording the neuronal activity on that. Okay, next one. This is how the patient is positioned in the frame. Next one. So some more photographs there. So basically, you drill a tiny hole there and then do the probe. So it's not a big operation. It's like trepanation. Next one. And that's where I'll start putting the electrode through that. Okay, next one. And then you do post-op scans, and there are special softwares now that will tell you where exactly you are in relation to those nucleus. There are different types of software. Next one, please. You have to verify where you are. Okay. Okay, next one. There are different types of this. Then there's, of course, a closed-loop DBS now where it will again record the neuronal activity and adjust the stimulation accordingly. So that's the latest advancement. Next one. Let me just quickly move to epilepsy surgery. Not all patients are candidates for epilepsy surgery. There are some patients who are definitely candidates and we can cure them. Okay. You need to know where the seizures are coming from. Next one, please. So you do electroencephalogram or EEG, and that will tell you which side of the hemisphere it's coming from. But it won't be accurate to pinpoint to say where exactly it's coming from. Next one. You may have to then do a video telemetry where you do EEG for continuously 7 days, as well as monitor their EEG for 7 days. You can actually see them having a fit and then see what is the electrical activity. That will tell you where exactly these seizures are coming from. Next one. And you need to know sort of, depending on where the lesion is or from what type of epilepsy, you have different manifestations. Next one. Sometimes we do this fancy test called WADA test, where we can anesthetize half the brain and allow the other half of the brain to be active. Okay? So if I'm not sure whether the person is right-handed or left-handed, or which side supports memory or language function, you can anesthetize one half of the brain and do the testing on the other half. Okay? Next one. And sometimes we put sort of multiple electrodes in their head, again to kind of monitor the electrical activity to pinpoint and say where the fits are coming from. Sometimes we put electrodes over the brain to record the electrical activity. The most common procedure is what is called a hippocampal sclerosis. This particular structure is called hippocampus. It's subserves memory. And if that is atrophic, they get what is called a temporal lobe epilepsy. And so we can excise that if I can show that seizures are coming from that particular area. Next one. So this is how we do the temporal lobectomy, where you take off a bit of skull there. Take off the next one. Sometimes we do focal resections. If I can show that tumors or seizures are coming from one particular area of the brain, you can go and target that particular area. That's again just a hippocampal resection. Very rarely we have to chop off half the brain. Okay, in some young people where half the brain is already destroyed and that half of the brain which is useless but is giving you a lot of epilepsy, the seizures activity, you can just take off half the brain, and that works very well as well. Okay, next one. If you can't do any resective brain surgery, you implant vagus nerve stimulator. So you put the electrodes on the vagus nerve here and put a battery there. That doesn't eradicate this epilepsy, but it sort of reduces the frequency and severity of the seizures. Okay. This is spasticity. As I told you, patients are quite stiff. It's difficult to look after them. You still see multiple sclerosis or patients who have head injuries. And if all physiotherapy has failed and all medication has failed, you need to do something. Otherwise, if it's so stiff that you can't even do toilet care there. Okay, so that's where I then implant what are called as baclofen pumps. Next one. So this is how a pump looks like. It's a programmable pump. It's good. You can program it from outside. The catheter goes into the spine, and we insert baclofen. It's a drug which reduces the tone of the muscle. So the baclofen is going directly into the spinal cord. Next one, please. So that's why you can see the pump is implanted in the tummy here, and the catheter goes into the spine, and it keeps delivering baclofen into the spine. Okay. Next one. And the last one is trigeminal neuralgia and neurovascular conflict syndromes. These are a group of conditions where we now know that it's blood vessel which is touching on the cranial nerve giving rise to problem. So if it's touching the trigeminal nerve, you get trigeminal neuralgia. If it's touching the facial nerve, you get hemifacial spasm. Or if it's touching the glossopharyngeal nerve, you get glossopharyngeal neuralgia. That's why it's called neurovascular conflict syndromes. In the ancient times, we didn't know how to treat this. Next one, please. So this is a famous toothache man in Wells Cathedral, not far from Salisbury in Somerset. And the legend is that patients who had trigeminal neuralgia used to go and pray in front of this toothache man in Wells Cathedral, and they would get rid of the condition. I wish it was true, but that is the famous toothache man. During that time, dental caries was very uncommon, so all these patients actually had trigeminal neuralgia. Next one. Now we know that it's because of the blood vessel which is impacting on the nerve. You can clearly see that this is the trigeminal nerve, and this is the superior cerebellar artery which is constantly, hitting the nerve, and that causes, what is called as demyelination, or it destroys the insulating coat of the nerve, and there's electrical short circuits there. Okay, so what you have to do is move the artery away from the nerve and put a sheet of Teflon or a felt of Teflon, which is the next one. So this is the Teflon that I've put it here. So once you leave that, separate the artery from the nerve, that practically cures the condition. Okay, no more neuralgia for the rest of the life. It was a fantastic operation where you can improve the quality of the life. Okay, next one. Another example, this is the nerve, that's the artery there, which is really sitting on the nerve there. Next one. And then I've separated it, moved the artery away, and put the Teflon there. Okay. In some patients, of course, elderly patients, you can't do big brain operations, so we do what is called as a balloon compression, where we insert a needle, and through the needle we'll insert a catheter and inflate a balloon, and it has to sort of take the shape of a pear for it to sort of compress the trigeminal nerve to give that pain relief, typically for 2 to 5 years, but pain will come back. It's not a curative procedure, but for patients who are 70, 80, who are not candidates for a big brain operation, you could do this. So functional neurosurgery is one place where do no harm is really relevant. As Robert Hutchinson, who was a physician in London, would say, from inability to let well alone, from too much zeal for the new and contempt for what is old. You don't want to do too much of new things. Also, you don't have contempt for what is old. From putting knowledge before wisdom, science before art, and cleverness before common sense. And from treating patients as cases. Never treat patients as cases. They are human beings, so you have to be very careful of that. And from making the cure of disease more grievous than the endurance of the same, good Lord deliver us. That's a very famous quote in medicine, which you always have to remember that it's a patient who is a human being that you're treating. Okay. Next one. So what's the future? Neuromodulation is quite exciting. There are a lot of stuff that's coming up. Next one. So this is brain-computer interface. Is what is the thing now. You can either have non-invasive by putting electrodes on the head, or you can implant the grids and then have a semi-invasive one, or you can have that sort of chip implanted in the brain to control brain activity. Next one, please. You must have seen this Neuralink from Elon Musk. It's all part of the sort of brain-computer interface. It's not all ready clinically, but it's going to come soon. These are bionic implants which you implant in the neuromuscular junction in patients with stroke, and using external thing you can control their arm movements. So these are all clever implants that engineers design. Next one. So COVID-19, of course, has affected everybody, but we have devised different ways of working through COVID-19. We were fortunate that we're one of the few centers in the country where we managed to carry out a large number of implants despite the lockdown, what have you. But of course, different ways of working. We now do a lot of online consultations, telephone follow-ups, etc. But it still has impacted on your waiting list and the way you work. There's no doubt about that. So, next one, please. Okay, I'm going to end that. Medicine's career is, I think, quite exciting. There's no doubt about that. You need to be passionate about it. That's the key thing. If you're not interested, you shouldn't do that. But if you're interested, you'll find there are different areas that you can specialize in. Okay. Next one, please. I would strongly recommend some of the books if you want to read more about neurosurgery, or that one. So you want to be a brain surgeon is all about medical career, different sort of specialties. So this is a good read for you guys. Okay. Thank you. Next one. I think it's the last one. Okay. Yeah. Well, for which condition, sorry? Any pain.
Yeah.
Oh, but I mean, for example, microvascular decompression, that's the operation for trigeminal neuralgia. That is, patient wakes up pain-free, and that's it, rest of the life they are pain-free. Yeah. That is one very satisfying operation. Spinal cord stimulators, you're not getting 100% pain relief, but significant enough for them to have improved quality of life. Yeah. And, when they switch the stimulator off, pain will come back. When they switch it on, pain will go away. So you know that pain is still there, but it's only masking the pain.
Sorry, also, is there a pathway, if treatments don't necessarily work as well, is there a pathway after that?
Oh yeah, there's a very robust selection process, and there's sort of various flow charts that we work through. There are different protocols, they should not try these drugs, they should understand what chronic pain is, how to manage themselves. They should see a psychologist, make sure that they don't have any depression or any other psychological problems. It's only when they have gone through all that, they then come for any intervention thing.
Thank you very much. Any other questions?
On like a typical day, what kind of stuff would you actually do? So it'd be like a surgery every day, or is it?
No, I mean, because we are 14 neurosurgeons in the hospital, you can't do surgery every day. So a typical week runs like this. Monday, either I'm operating in private in the morning, and then afternoon I'll have a clinic. So either I do my functional neurosurgery clinic, or once a week I have sometimes a joint neurosurgery and neurology clinic where I see patients with movement disorders, Parkinson's disease, with the neurologist. Sometimes once a month I have joint neurosurgery pain clinic where the pain consultant is with me to assess these patients for chronic pain for spinal cord stimulators. Tuesday typically spend a whole day in private hospital. Wednesday, most Wednesdays I'm on call. So you then admit all the trauma, all head injuries, any other neurological emergencies, stroke, a lot of aneurysms, subarachnoid hemorrhages, etc. So you deal with those emergencies on Wednesday. Thursday and Friday is what I operate. Thursday is when I do most of the operation. Sometimes I operate in a different hospital as well. Friday, typically either theatre or we have a lot of multidisciplinary team meetings where all these patients have to go through MDT meetings to make sure that all the boxes are ticked and everybody's happy. It's a collective decision rather than one person's decision. So all those MDT meetings happen on Fridays. There's also, we have once a month what is called as mortality and morbidity meeting. So every month we go through all the patients who have died, usually all the patients who have had severe head injury or stroke or subarachnoid hemorrhages. We also discuss morbidities. If something has gone wrong, what went wrong, how can we improve? So it's a constant sort of learning that happens in that meeting.
You mentioned it's quite an emotionally intensive job, and like obviously there will be times when it goes wrong. How do you find? How do you deal with that yourself?
Well, I mean, it's difficult sometimes when you have done everything and the outcome is not good, and it does happen. As long as you have done the best you can, patients are always going to, if it's a bad head injury, it's very difficult for you to save them. You try your best, but then you need to be a bit emotionally strong as well. How do you tell the patient's family members? How do you sort of tell the news about bad outcome? Or even some patients who are pretty bad, and I know that surgery is futile. There's no way he's going to survive. How do you then decide how to go for, do not resuscitate, or tell the patient that this is just palliation, I can't do anything. So those are the things that we deal day in and day out. It can be sometimes quite taxing depending on the type of patients or the relatives you encounter. But you're not alone in that room. Okay, you have family members. You have your registrars, the neuro ICU consultants. So there's a team here, the nurses as well. So all of us are, you have to be very empathetic and, deal with it very